Hello, this is Kim Jong-il. Today's subject is part 2 of orthodontic differential diagnosis. We go through the aesthetic analysis, SEF analysis, and model analysis for comprehensive orthodontic diagnosis. And it is important to pay attention to 1. Extraction or non-extraction, 2. Which teeth to extract, and 3. How to treat. Class 2 malocclusion is large, divided by cases with maxillary protrusion and cases with mandibular retrusion. In case of a maxillary protrusion, headgear or miniscrew can be used to move the entire maxilla posteriorly. On the other hand, in case of a mandibular retrusion, functional appliances can be used in order to move the mandible forward. Many previous studies claimed higher incidence of maxillary protrusion in Class 2 malocclusion. But recent studies report that there are much more cases of mandibular retrusion. Therefore, there are more cases in which the mandibular forward movement is needed. SEF analysis can be used as a fundamental analysis for differential diagnosis of non-ext prognathism vis. Min retrusion. There are 3 methods for this diagnosis. 1. Draw a Bayesian perpendicular line with reference to the FH plane and measure the anteroposterior distance from a perpendicular line to a point or pogonion. 2. Effective non-ext length, which are the distance from condylean point to a point and from condylean point to gnathian respectively, can be measured to evaluate where the discrepancy stems from. 3. Angle of convexity, which is formed by the intersection of the facial plane and pog to point A to pogonion, shows the relative anteroposterior positions of A point and B point. These are famous actresses. Asians and Caucasians have different types of skull. Asians are brachycephalic, characterized by the short distance from cella to nasion. On the other hand, Caucasians are dolichocephalic, characterized by the long cella to nasion distance. When assessing profile, the reference plane is generally selected in the natural head position. Horizontal and vertical lines passing through the subnasal are drawn in the natural head position to evaluate the positions of a point and pogonion relative to these lines. This patient has retruded mandible in profile view and an excessive overjet in a lateral intraoral photo. Here is the patient's cephalometric analysis. The red dotted line represents Bayesian perpendicular line. According to Hay, which is the facial angle, the mandible is in a normal position. A B-plane angle also indicates a normal anteroposterior relationship. As you can see, cephalometric and aesthetic analyses can have different results from each other. This patient has a large overjet. Facial angle 85 degrees and a B-plane angle -3 degrees indicate class 1 skeletal pattern. Then which analysis should be considered first, cephalometric analysis or aesthetic analysis? I look at the aesthetic analysis first. In aesthetic analysis, current profile is evaluated whether it is acceptable or poor. This patient with class 2 skeletal pattern has retruded mandible. In class 3 as well, horizontal and vertical reference lines are drawn to evaluate anteroposterior positions of the maxilla and mandible. For class 2 skeletal pattern, profile at edge bite is evaluated by protruding the mandible. Due to large overjet, the maxilla appears to be protruded. At edge bite, the patient's face looks a bit long, but profile is improved by forward movement of the mandible. These are the intraoral photos at CO bite. And these are the intraoral photos at edge bite. If edge-to-edge bite results in protrusive lips, the profile is poor, which means that the maxilla is prognathic and the mandible is in a normal position. In addition, profile is poor if lower anterior facial height LAFH, which is the distance from ANS to menton, becomes too long at edge-to-edge bite. On the other hand, if edge-to-edge bite leads to a good profile, it means that either the maxilla is normal and the mandible is retrognathic, or that there is a vertical deficiency problem. This is a class 3 malocclusion patient with anterior and posterior crossbite, mild crowding in the lower arch, and moderate crowding in the upper arch. In this type of patient, profile is evaluated with the mandible retruded as much as possible. It is best if edge-to-edge bite is possible, but it may not always be so, especially when there is a skeletal problem. This is the patient's profile at CO. As you can see, the mandible is protruded. However, when the mandible is retruded, the patient looks much better from both the front and profile. So for clinical analysis, profile with retruded mandible is evaluated first. If profile is poor, it means that the maxilla is normal but the mandible is prognathic, or that lower anterior facial height is too long. On the other hand, if profile becomes good as the mandible is retruded, the patient likely has normal mandible and retrognathic maxilla or vertical deficiency problem. Many different aspects are assessed for class 3 malocclusion, such as a. Whether edge-to-edge bite is possible, b. Genetic predisposition and familial history of mandibular prognathism, c. Lip seal, d. Profile at edge-to-edge bite, e. Development of midface around zygoma, which is closely related to the growth of maxilla. If zygoma is poorly developed, it will be hard for the maxilla to grow forward. And lastly, LAFH is assessed. This patient shows mismatching midlines. The canine K is class 1 on the left but full class 2 on the right. In this case, facial appearance is evaluated after matching midlines. Since the canine K is class 2 on the right, profile can be evaluated with protruded mandible. From profile at CO, the mandible is in a retruded position. From the front, lip canting and short LAFH are observed. By matching midlines and protruding the mandible to edge-to-edge bite, the patient's facial appearance from both profile and the front is improved. In case of midline deviation, lip canting is assessed with matching midlines. If the lips are even, the facial appearance is good and the patient can be treated with orthodontic treatment only. On the other hand, if the lips are canted, there may be skeletal problems and orthodontic treatment may not be sufficient. In other words, surgical treatment may be necessary in order to fix lip canting. After aesthetics is evaluated, the next factor to consider is CF. Low-angle patients have round faces while high-angle patients have long faces. At first, the terminology is confusing because high CF means low angle and vice versa, which is counterintuitive. CF is the sum of ODI and APDI, so it is not necessarily related to facial appearance. If CF is high, the muscle activity is relatively high as well. On the other hand, if CF is low-high angle, the muscle activity is relatively low. McLaughlin stated that non-extraction treatment should be carried out in low-angle deep bite cases. However, if crowding and/or protrusion is excessive, then premolar extraction treatment may be necessary. and proper treatment mechanics are required in order to prevent collapse of the vertical dimension. Then how is low-angle deep bite case evaluated? Is it by the mandibular plane angle? He also stated that the extraction of premolars is often helpful in the treatment of high-angle open bite cases. However, the bite closure is due primarily to anterior dental changes rather than skeletal changes, involving closure of the mandibular plane angle. In this case also, how is high-angle open bite case evaluated? This is the case report format for a BO specialist certification. Indeed, these are very useful measurements. But when these measurements are schematically drawn, the occlusal relationship between the maxilla and mandible is missing. On the other hand, in MEAW orthodontics, palatal plane, IB plane, mandibular plane, occlusal plane, and the upper and lower incisor inclination are included to provide an accurate assessment. In MEAW orthodontics, the anteroposterior relationship axis is evaluated by a PDI and vertical relationship axis by ODI. According to this diagram, non-extraction treatment can be carried out if CF is higher than 155, and extraction may be necessary if CF is less than 155 or especially if it is less than 150. In MEAW analysis, palatal plane, IB plane, and mandibular plane form the abmaxillomandibular triangle. This triangle includes three angles, which are IB to mandibular plane angle ODI, IB to palatal plane angle IPDI, and palatal plane to mandibular plane angle. The sum of these angles is 180 degrees. Therefore, the angle between palatal plane and mandibular plane is 180 minus ODI plus APDI. Since ODI plus APDI is CF, the angle between palatal plane and mandibular plane is 180 minus CF. McLaughlin measured the palatal plane to mandibular plane angle to classify low angle and high angle. However, in MEAW orthodontics, the addition of AB plane makes it easier to evaluate ODI, APDI, and CF. As a result, the anteroposterior relationship class 1, 2, and 3 and vertical relationship low angle and high angle can be classified with ease. This patient on the left has ODI 80, APDI 78, and high CF of 158 that indicate low angle type. Profile is acceptable, and the lips may appear slightly protruded because of decreased vertical dimension. On the other hand, the patient on the right has ODI 71, APDI 73.5, and low CF of 144.5, with long face and protrusive lips. It is difficult to treat this patient with non-extraction approach. After the evaluation of CF, whether non-extraction approach is possible or not should be considered. If enough space can be gained, non-extraction approach is possible, but if not, teeth have to be extracted. Then occlusal plane should always be considered for extraction option and treatment method. That is, whether to extract or not and how to treat should be based on the adjustment of occlusal plane. Rotation of the molars can also be considered in extraction option. The buccal surfaces of the upper first molars should be parallel, and this feature is called parallel rotation. But when they are mesially rotated, it is called mesial rotation. In which case is it easier to gain space? In case of mesial rotation, space can be gained by derotating the molars. On the other hand, in case of parallel rotation, there is no room for derotation, so space gaining method is limited to expansion and posterior movement. In the lower arch, there can be a deep curve of SPE or a flat curve of SPE. In which case is it easier to gain space? When the teeth are upright, there is a limit to the amount of bodily movement of the posterior teeth. On the other hand, if the teeth are mesially angulated, space can be gained by uprighting them. In conventional orthodontics, deep curve of SPE is usually an indication for extraction treatment. But in MEAW orthodontics, non-extraction treatment is the primary option in this case, because space can be gained by uprighting. POP can be either flat or steep. In which case is it easier to gain space? In case of normal POP, it is difficult to change POP. However, in case of steep POP, space can be gained by flattening POP. This topic will be discussed in detail in the next lecture. Thank you for watching.